Tell us what frozen shoulder is.
Frozen shoulder is something that we see very commonly in the clinic. I personally see an awful lot of frozen shoulder. It's actually a very, very painful, debilitating condition. And it's interesting because you can't really see anything from the outside. It's not like it's swollen or anything, but people can be in agony. The classic person that gets it will be between the ages of 40 and 60. It's actually very rare to get frozen shoulder before 40 and after 60. It does happen, but it normally fits into that bracket. It is women more than men. It actually, this is quite an amazing stat, it affects 2 to 3% of the population. So 2 out of 100 people get it, which is a lot. And if you've got conditions such as diabetes, that goes up to around 20%. So it's something we see a lot of. It's very painful. It's generally worse at night. As I said, it affects women generally more than men, but men do definitely get it. And it causes pain. It could be down the front, the side, the back of the shoulder. Sometimes people can get pain up into the neck, but it is mainly that sort of, call it the regimental badge sort of pain. And as I say, it's painful at night, and normally it comes with a very restricted shoulder, hence the pain, the phrase frozen shoulder. The actual medical term is adhesive capsulitis. And most people with frozen shoulder are very restricted in their range of movement, and they can't move much above 90 degrees coming out to the side, and they're really restricted in their rotation. So moving their arm out, the classic thing of trying to get something from behind you or in the back seat of the car causes excruciating pain.
And are those the things that you find that people say first? So they come to you before they can't quite lift up their hand, or they come earlier and there's certain activities that they're not able to do?
Yeah, good question. I think actually the main reason people come to us is because they're in agony. Right. And as I said, it's such a painful condition, and they walk in and sometimes they don't look very well because they've not slept much at all. They look quite grey, tired, because they're in a lot of pain. And I do also find there's people that have been living with this for quite a long period of time and haven't been able to get the help that they need. They might have been given painkillers, but actually it's not common that these painkillers work. And actually there's not a lot, unfortunately, that does help with frozen shoulder. The good news is it does go, and we'll come on to that. A lot of people have tried hot packs, ice, rest, painkillers, maybe a bit of physiotherapy, and unfortunately even physiotherapy, particularly in the early stages, doesn't help frozen shoulder pain.
And is there like something specifically that people think that they've got before they come? So is it regularly re-diagnosed as something else?
Yeah, well, pain down into this region of the arm could be about 6 or 7 different things. So yeah, it's quite common that they do have a misdiagnosis sometimes. But also, frozen shoulder can develop. So you may present to your GP and they may diagnose you with an impingement or something like that. And it may well be that, and that's where you get pain, but you've still got okay movement. Particularly if you use the other arm to move it, you can still use it. But then you can end up developing a frozen shoulder. The other people that get frozen shoulder are people that you can actually get it after surgery. And you can also get it, for example, if you've had a fall skiing and you've just got a sort of minor injury, or you've fallen off your bike and you think, oh, okay, I'm okay. But over the next couple of weeks, you start to develop a stiff and painful shoulder. And that's when you've developed frozen shoulder. But most people, they can't remember any reason for it. So it just comes on. So that's what's so odd about it, is you end up in agony, but you've actually not done anything.
So how do you actually get rid of it? Like, what would you do to someone when you told them they've got frozen shoulder?
Yeah. Look, first of all, you get the right diagnosis, and a couple of things. The first thing is to explain what it is, so people can get a really good understanding of what's going on in their shoulder, and also for them to understand that it is completely benign, because these people can be in 10 out of 10 pain, not sleeping at night, and they just need that reassurance that it's not nothing to worry about because they're in agony, but it will get better. And that's the message I always get across to people. Frozen shoulder doesn't last a lifetime. It, on average, will last between 1 to 2 years. Wow. However, and what's really important is that it goes through stages. So we often see them in the painful stage, what we call stage 1. That can sometimes last only a month. Sometimes it can unfortunately last a lot longer than that, several months, 6 to 12 months.
Is there a reason for why it could last longer?
From my understanding, I did end up doing my master's dissertation in frozen shoulder, which was really interesting actually, because I interviewed people with frozen shoulder and I really got an appreciation. I mean, there was women saying this is worse than childbirth, and I will never understand that, but it sounds pretty bad, doesn't it? So it was really interesting, and I definitely got a lot more empathy for people when I started to find out how debilitating this is, and they've got nothing to show for it. And that's really hard. I'm in agony. It looks all right to me, but it's really painful. So, sorry, what was the question?
So how long does the painful stage normally last?
Okay, so it varies, but hopefully it's gone within 6 months. Okay. But it does go on for longer sometimes. So that's the first stage, which is the painful stage. And then you have like a stiff stage where it's not so painful, but stiff. So you can't move your shoulder, but you're in less pain. And then you've got the third stage where it's like the thawing, the thawing phase or the improvement phase, where that stiffness goes and you're back to normal. But that process can take 1 to 2 years.
So if we go back to the pain, if someone comes to you and they are in a lot of pain, how would you tell them to manage it?
Yeah, so the first thing, you would always try your basics. So try and reduce the activities that are painful. So if you play tennis, well, you won't be able to play tennis with a frozen shoulder. Maybe, speak to your GP or a pharmacist about painkillers and that sort of thing. But the honest truth of the patients I see, but bear in mind they're the ones that haven't got better, it's either a matter of holding tight and waiting for that painful stage to go, because it does, or it's looking at other options that can help with pain relief. Now, in our clinic, we've got lots of physiotherapists that will do soft tissue treatment, massage, acupuncture, and give general advice around exercises. And we would always say that you would try that first. But I'm slightly biased because I spend half my week doing ultrasound-guided steroid injections. And one of the reasons I wanted to talk about frozen shoulder is because I want people to be very aware that a steroid injection for frozen shoulder is appropriate and medically, scientifically proven to be the best or one of the good options for it. So I think our job as clinicians is not to tell people what they need, but to inform them and educate them about what their options are, what the side effects are, what the chances of getting better are, and then let them make the decision. What I find is that everybody with a frozen shoulder that can't wake up at night, that is in agony and really struggling to see the end of this thing, they can't pick up kids, they can't sleep at night, they can't go to work, they can't do tennis, and that's how bad it is sometimes. They are very happy to go ahead with a steroid injection.
And you kind of mentioned these activity limitations. Do you find that there's always the same thing, like it's putting on your coat or putting a ticket in the machine? Is there things that people will regularly say to you, this is actually bothering me and I can't do it?
Yeah, a lot of the time it's everything. Okay. So most people with frozen shoulder can pick up a glass to their mouth, no problem at all. They can do up their buttons at the front. They might be able to do some gentle exercises to 90 degrees, but they can't put their hand behind the back. So women putting on their bra, they either stop wearing bras because it's so painful, or they do it up around the front. Reaching back in a car, reaching up to a cupboard, almost like anything that comes slightly out of this sort of space here becomes very painful.
So you can, like, for example, lift your child here, but you couldn't put them over there?
Not with a frozen shoulder. And frozen shoulder, although it's quite clear, it's very clear how to diagnose it. That's the other thing, is diagnosis. You don't need an MRI scan, and you don't need any sort of imaging to diagnose a frozen shoulder. That's really important. People always like, I need an MRI scan. No, you don't need an MRI scan. You need to see somebody that's very used to seeing frozen shoulder, and we can diagnose that very quickly through a pattern of tests.
Can you see it on an MRI?
You can see it on MRI, but it's a clinical diagnosis. So people that do require imaging are people where the diagnosis is not clear from the clinical assessment. Some people will get an x-ray just to check that there's no arthritis in the joint or anything else. And certainly if anybody has a history of, say, breast cancer or previous cancer, then we would probably do imaging, certainly before we did an injection, if that's what we're going to do. I use a lot of diagnostic ultrasound. I can look at the capsule. See, on ultrasound, you can look under the armpit or just up here, and you can see thickening of the capsule. But at most of the time, I've already made the diagnosis through just some simple passive tests.
Yeah.
And if it's a stiff shoulder that I can't move, you can't move it, and you're in agony, look, 90% of the time it's a frozen shoulder. But if we have any concerns, we will then send people for further imaging.
So let's go back to, you mentioned a whole load of different treatment options. Now, this is something that you're saying is going to last for up to 2 years. So you've mentioned massage, physio, acupuncture. Talk to me about what those things do, how they can help, if you should go for one more than the other.
Yeah, look, for a very painful stage 1 frozen shoulder, a lot of those things don't help. That is the reality of it.
Even short term?
It can help short term, so you might get a good night's sleep that night or the next day. But the term that we use in physio is the patient getting treatment carryover. So you treat them on a Monday, they feel brilliant for a day, but then they're just back to stage 1. So there's no treatment carryover between. And if that's the case, yes, you're getting some short-term relief. And for some people, that might help them get through that stage, which is going to naturally improve anyway at some point. But for a lot of people, they want more than that. They're fed up. Surgery, I've been doing this for about 20 years. Back in the day, they did do surgery for frozen shoulder. It's called a MUA, or a capsular release, which is where they basically, so what we haven't talked about actually is what is frozen shoulder. So you've got your ball and socket joint, and around the outside, it's almost like a sock that keeps the fluid inside the joint. That's called the capsule, and lining the capsule is something called the synovium. So the term capsulitis, the deep capsulitis, itis meaning inflammation. So you get inflammation of the capsule, which is a very strong structure. And when you see the capsule in a patient with frozen shoulder, particularly in the part of the capsule underneath the armpit called the inferior capsule, it's very thick, it's very red, it's very inflamed, very vascular, and therefore very inflamed a lot of the time. So what they do in surgery is they cut those areas and then basically pull your arm up quite hard and see if they can get it moving. I cannot remember the last time I've seen a patient that had that. It seems like it's got out of fashion, probably rightly so, probably because most of the time frozen shoulder can be managed conservatively, being patient, and obviously it depends how patient the patient wants to be, and injection therapy. And injection therapy definitely has a role in frozen shoulder. And I want people to know that, because they don't have to be sitting there in pain. There are options. It doesn't always work. But if you said to me, Chris, you could only do one injection for the rest of your life to get benefit to people, I'd say a frozen shoulder injection.
Okay, so then talk me through what that does. So I've come in, I'm in the painful stage, you've diagnosed me clinically as a frozen shoulder.
Yeah.
So you've taught me through injections. Tell me what's going to happen. So if I'm not the person that particularly, that whole thing of, I don't want to take medication, I don't really want an injection.
Yeah.
Why would I actually then have this injection? What does it do?
Yeah. So nobody has to have the injection, and I make that very clear. It is your choice. However, you should be informed of the fact that a steroid is an anti-inflammatory. You, in my opinion, and from the clinic I run Complete, every injection is ultrasound-guided. Because we need to make sure it's in the right area. If you've had an injection before and it hasn't worked and it's not been guided, you should consider another injection if it's not giving you the relief. But
if it's not giving you any relief at all?
If it hasn't given you any relief at all and you have a classic frozen shoulder, I would actually maybe get some imaging at that point, first of all, because I just want to check there's nothing else going on. But we know that 50% of unguided injections don't go in the joint. Okay, that's very well proven. So you can say that if it hasn't improved, it's three reasons, and this is important for people to know. Either you've got the wrong diagnosis in the first place, so let's get that right first. The second reason, it hasn't gone in the joint, so let's get one in the joint. And then the third reason is some people don't respond, and that is just the way it is. It's very hard to predict before you do an injection who will and who won't. Generally speaking, the ones that are really painful respond a bit better because obviously there's more potential for a reduction. And what we do is we put it into the joint. It takes me about 10 seconds to do the injection. We do so many, you get very good at it. You use the ultrasound to guide it into the joint. You put some local anesthetic, obviously, that's useful for the patient, and then we put some steroid into the joint. Doesn't take long at all. We would expect that to improve within a few days. Sometimes even that night. We've had lots of examples. Sometimes it takes a little bit longer. But there are some side effects, and we always will go through that with patients, and everything is about risk versus benefit. So if I couldn't sleep at night, I would go for that because I would be very, very miserable. But it's important that we just give patient the right information, tell them what the role of the injection is, and then they can make their own decision. And then we always follow that up with physiotherapy. Okay. And that's where physio can be really good for frozen shoulder after the injection.
So we'll come back to the physio stage, but with the injections, would you just do one? Do you have multiple? Is there different types of injections? Is it always a steroid?
Good question. It's always a steroid. We do other injections, PRP, hyaluronic acid, but there is very little evidence to support doing them for that because purely this is inflammation, and therefore you need an anti-inflammatory. Often tablets, anti-inflammatories don't work because obviously it's not targeted like an injection. So what was the question?
Is it just one injection? Is it multiple?
Yeah. So when I first did injections in the NHS, we had a protocol where we would do one every 2 weeks for 6 weeks. So it was 3 injections, one every 2 weeks. We don't do that now. We would just do one and see how you get on. Most of the time, we will do injections as a one-off. However, again, frozen shoulder is one of those conditions where you may need more than one. The most I've ever done this year is 3. But I would say on average, I'm doing definitely 1 would be my average, sometimes 2.
And you'd kind of get some improvement after the first one. So you'd wait to see how it was. Let's say it was 30% better, you'd go again.
Yeah.
30% better, you'd go again.
And that's in discussion with the patient. Some people after one, you take the edge off their pain, they sleep at night, they've still got a stiff shoulder, but they really don't care. They get a good night's sleep, they can do more activities, and then they're just happy to ride it out. And that's where physio definitely comes in to try and then restore the range of movement once it's less painful.
And will the injection change range of movement, or is it just the injection stops the pain, which allows then the physio to come in and help the movement come back?
And that leads me really nicely onto the 2 options that you have with injections. So as I said, they are both steroid injections. A simple steroid injection is local anesthetic and steroid, okay? And the primary reason for doing that is very simple. It's pain, okay? I will say to a patient, if your pain improves, you can then engage in more exercise, physiotherapy, so hopefully we get you more range of movement. And at that point, they've already consented to the treatment because as soon as you say, hopefully it will reduce your pain, they're normally on board with it. Obviously, we tell them it's not always the case. The second type of injection that has become a little bit more popular is something called a hydrodistension or a hydrodilatation, and we do a lot of those in clinic as well. So that is still a steroid injection with local anesthetic, but this time you add saline. So sterile saline for injection, and you put that into the joint. So you put in anything from 30 to 60 mils of fluid into the joint. So what that does is it stretches the joint from the inside to try and get more range of movement afterwards to help with your physio and your exercises, as well as getting the pain relief from the steroid. People often, well, which one should you do?
Exactly.
Yeah. If you've got the procedure itself for a hydrodistension or hydrodilatation where you add the saline is more painful. And, I said it takes like 10 seconds to do a steroid injection. This could take a minute to do.
Just because it's hard to push the...
Because it's hard and it's more uncomfortable for the patient.
Okay.
And so if you're in agony anyway, and somebody walks in, they don't look well, let's just get the steroid in. We can think about doing the hydrodilatation 6 weeks later and try and get you a bit more movement, but let's get the pain under control. And that's generally how I would clinically reason that and describe it to the patient. However, there's a group where they're not in so much pain, so they're not waking at night, but they're like, I just want to be able to move that shoulder. I've tried my physio, it's not getting anywhere. Then you could do a hydrodistension. We get the odd patient where they're not in any pain anymore, but they're just stiff. Yeah. And that to me is not an indication for an injection. An indication for an injection has to be pain driven first before you would to consider it.
So what would you expect people or a physio is doing in someone's appointment if they've gone through the painful stage, you're trying to get range of movement? What sort of treatments can someone expect to have, exercises, that sort of thing?
Yeah. So overall, the evidence for physiotherapy in a painful stage 1 frozen shoulder is not very good. In stage 2, there is some evidence to support that at that point, physio is a good thing to do. It's going to be exercise based. It's also going to be some hands-on treatment to release the muscles around it. And at some point, once your range of movement is better, we're going to get your strength back and get you back to full function. And I think, but you have to be in less pain. Otherwise, physiotherapy can aggravate your pain. And if anybody's watching this and they've tried physio and it's getting worse with treatment, that's a really good indication that you may have a frozen shoulder.
Is there, like, how much compliance do I have to have for exercises? You know, it's very easy for somebody to come in, get some soft tissue work, go to a massage therapist, soft tissue therapist, and get that done. Is that enough, or do I have to do those exercises?
Yeah, you have to do it. It's the combination, absolutely. And it has to be done pretty regularly. And most of the time, once you've got some of the pain under control, whether they've just ridden it out or whether they've had an injection, people are really quite motivated at that point because they want to get back to full function. But although physiotherapy is very important at that point, as we've said at the beginning, frozen shoulder almost has a life of its own and you need to ride that out. So time is a massive healer for frozen shoulder as well. I think one of the things that's quite interesting is there's a paper that's come out recently that said that up to 25% of people still have stiffness 3 to 4 years down the line. So your pain's much better, but
stiffness?
Well, it varies, but just, you know, if you bring them out, they just don't have quite the range. But actually, if you add physiotherapy, from my experiences, you can get the full range back, but you just have to push the patient a little bit more.
The physio has to manually push the patient?
No, it can just be push it in exercise or manual therapy. But I think, obviously, you're not going to have physio for 2 years, so it's about continuing on with the exercises that you've been given to make sure you get a full recovery, not a 70-80% recovery.
So what about, you know, if you're kind of in that pain coming out of it, maybe had an injection, maybe not, what are the strategies that I could use to help manage my pain? Is there any particular position, sleeping position, slings? Like, what is it that I could use?
Yeah, so when you start to feel less pain, you definitely need to go with it. So you're going to start doing more exercises. If you're in absolute agony, you've not had an injection or an injection hasn't worked, then it's important to use the right sleeping positions at night. So you might use a pillow underneath your elbow, or I think we're going to do a video with showing some sleeping positions. So hopefully that will be useful for people. And also obviously think about, are you on the right medication and that sort of thing to try and help with the pain. But if somebody walks in and says, I've tried everything, nothing gets better, that is like diagnosing their own frozen shoulder, because it does not respond to your classic things that you think will make it feel better.
Okay, so tell me how, me as a person, if you had to summarize, how do I definitely know it's a frozen shoulder?
See somebody that, look, I you know, there's a lot of information out there on Google and self-diagnosis and that sort of thing. But the bottom line is, if you're not waking at night, you've got a problem and you need to go and get the right information. If you're waking up at night, and or it's just not getting better, then you definitely need to see an expert, somebody that has spent their life looking at frozen shoulders, and getting the right information, and also double checking you have a frozen shoulder. As a self-test, which I think is what you were guessing at, that. So if you just put your elbow into the side here and you try and with your other arm, you push your arm out, you should get to like 70, 90 degrees, something like that. Okay. If you're getting nowhere, you've probably got a frozen shoulder or you've dislocated it. If you've dislocated it, you should know about it. The other reason you can get a stiff shoulder, there are a couple of other reasons, but a stiff shoulder could be related to osteoarthritis. And that's why often if you're older than 60, we have to think about whether this is arthritis, not frozen shoulder. If you then bring your arm up there, if you can't even do that, you may well have a frozen shoulder. And then normally that's even more restricted doing that. A lot of the time, frozen shoulders don't even want, they can't even get up there. But calcific tendinopathy, acute calcific tendinopathy, a really bad rotator cuff tear, a really bad bursitis can also present similarly, because when you've got a lot of pain, you could easily be restricted in your movement if you're testing yourself anyway, and that's why you need to see somebody that can test you properly in clinic.
And do you need to have an ultrasound for that, or can it be through purely physio special tests?
Yep, so a physiotherapist with the correct experience should be able to diagnose a frozen shoulder. If it's a simple frozen shoulder that presents like a classic frozen shoulder, you've got no other past medical history that we're concerned about, then you don't need imaging.
Okay. And so you mentioned right back at the beginning it affects men more than women, women more than men.
Yeah.
But it always takes us kind of up to 2 years. Why? What are the causes? And, how can I bring that a little bit closer?
Yeah, so it varies a lot how long it lasts, but people will Google it, won't they? And they'll see years and years. So let's say it does often last that long. The key thing for people to remember is that you've got to get out of that painful stage as soon as possible. And to some people, that will just happen quite quickly with painkillers, a bit of physio and that sort of thing. But for a lot of people that we see, they're still in that painful stage because they've sought help. The injection should take you from stage 1, the painful stage, into the stiff stage. So honestly, that is the injection side of it. I'm biased because I do injections. I think that is going to be the best way of reducing the time frame. Doesn't mean it's a quick fix. Don't get me wrong, I've had some miracle results with these things, and I've also had some not so good results. I've had people 2 days later where they've got full range of movement and it's like it's never happened. And I've got people where they're like, well, it's not really helped, Chris. But as I said, there's definitely a role, and people need to look into it if they're suffering with a frozen shoulder. Even if they don't do it, they need to be aware of what their options are.
So final question. What would be your 100% top tips for someone who thinks they might have a frozen shoulder?
I wanted to give one really good top tip, but
I'll give you 3 to 5.
Okay, so one is, have you definitely got a frozen shoulder? That's really important.
So appropriate diagnosis.
Appropriate diagnosis. Treatment-wise, see somebody that's seen a lot of frozen shoulder, like a lot.
How many is a lot?
I inject about 5 to 10 a week. Okay? I don't want everybody to see me, and not everybody, but just see somebody that sees a lot of frozen, or a lot of shoulders, because this is a straightforward diagnosis if you see a lot, okay? If people are unsure, then they should, of the diagnosis or the clinician, then, normally you need further imaging at that point, but barn door frozen shoulder is quite easy. So the second thing is see somebody that's seen a lot to get all your treatment options mapped out to you. So there's no point me knowing, I know. You as the patient need to be informed with what all of your options are, and then you can make an informed decision as to what you should do. And my third tip is part of that should be consideration of an injection, whether you do it or not.
Cool. So we've got, make sure you've got the right diagnosis, see someone who sees a lot of shoulders, know all your treatment options so that you can then potentially have the injection. And what about committing to that physio and stuff afterwards? Does that really change things?
It really does, but you've got to be out of the painful stage. So actually, that's a really key message. If you're committing to physio, that's great, but you've got to be getting that carryover. And if you're not, then I wouldn't continue with it. You've got to be getting some improvement over, say, 2-3 sessions where you get this carryover. Otherwise, you may need to be looking at other treatment options.
Brilliant. Thank you.
Pleasure.